Good afternoon, everybody. I'm Lisa Napolitano. I'm president of the Florida CBT Association. And on behalf of the organization, I want to welcome you to this professional training webinar. Just by way of information, FLCBT is dedicated to the dissemination of CBT and the promotion of community among Florida-based mental health practitioners. And throughout the year, we're going to be offering a series of professional training workshops by experts in our field with topics ranging from motivational interviewing, radically open DBT for affectively constricted disorders, inference-based CBT for OCD, acceptance and commitment therapy, and emotion regulation therapy, just to name a few. So if you haven't already, please check us out at flcbt.org. For today's talk, I'm thrilled to introduce someone who in many ways needs no introduction. Dr. Jonathan Abramowitz is a world-renowned expert in the field of OCD and anxiety disorders, including fears and phobias, health anxiety, and panic attacks. He has authored over 350 scientific publications and 20 books, and has served as editor of several academic journals. He is the past president of the Association for Behavioral and Cognitive Therapy, and is currently a professor and the director of clinical training at the University of North Carolina at Chapel Hill in the Department of Psychology and Neuroscience. And Dr. Abramowitz will be speaking with us today about inhibitory learning, as you all know, and ERP. We're going to have time for Q&A at the end of the presentation, so we ask that you hold your questions until then. And Jonathan, thanks so much for being with us here today, and I'm going to turn it over to you.
My pleasure, Lisa. Thanks very much for having me. Hello to everyone in Florida. And it is a pleasure to be here and talk about one of my favorite topics, which is treatment of anxiety and fear and all that stuff. So I'm going to share my screen and bring up my slides. There we go. Hopefully you all can see that. And like Lisa said, what we'll do is we'll talk for a little while about this, and then happy to answer questions and all that stuff. We'll save plenty of time for that. I call the talk Desirable Difficulties. And we'll touch on that a little bit later as we kind of go through all of this. But that's really the theme of exposure therapy through an inhibitory learning lens, that we want to make the treatment in the moment more challenging. And because in the end, that's going to be more desirable. That's going to help the person even more. So hopefully by the end of this, you'll understand. And this is just our agenda. We'll give I'll give a broad overview of kind of how anxiety and fear work and how they're extinguished. We'll talk about kind of an older model. Not necessarily it's like we should throw it away, but an older kind of the original way of thinking about exposure therapy, which is emotional processing theory. And then we'll spend the rest of the time talking about an inhibitory learning approach. And most importantly, for you all, giving you all some strategies that hopefully, you can turn around and use with the next person who shows up in your office. So we'll kind of go quickly over this because you're probably familiar with a lot of this material. But what is anxiety? Anxiety and fear, right? And stress and worry and all that. This is the body's response to the perception of threat. Right. And we think of it as the fight or flight response. It's our body's kind of adaptive way of preparing for that perception of danger. When we perceive a threat, oh no, here comes the saber-toothed tiger, right? If we were living, hundreds, thousands, I guess, of years ago. Or now it's, oh no, I have that first date or a job interview or, an exam. The fight or flight response swings into action, wonder of wonder, miracles of miracles. We get a release of adrenaline and cortisol, and our muscles become tense, and we all know what that experience is like. Fortunately, for most of us in the world, it's not life or death like the saber-toothed tiger anymore, but still, anxiety and fear help us to do our best. If I didn't have at least a little bit, kind of in the happy zone of stress about doing this talk, for example, I wouldn't be prepared, I would be cocky, and things wouldn't go that well. So we want at least some degree of anxiety can be helpful. And again, it's all members of the animal kingdom. So anxiety, fear, this is our friend, right? A lot of people with anxiety disorders, they perceive fear as the enemy, something we got to get rid of. And one of the things that we want to teach them through a treatment like exposure is that no, this is your friend. Like we talked about, it's triggered in a response as a response to an overestimate of perceived threat, but it's not dangerous. The responses that we have, physiological responses, muscle tension, heart racing, all that fight or flight stuff. The cognitive or affective response, so we catastrophize and we, have that sense of doom. And then the behavioral response, which usually amounts to things like escape and avoidance. All of these things are protective. They help us to survive. They've all helped us to survive through our lives, probably. When a person has pathological, extreme clinical levels of anxiety and fear, then this is happening when the stimuli don't really call for it. The person is more anxious than the facts warrant. They're perceiving a threat when the threat is not in proportion to the perception. Or the perception, I guess, is out of proportion, exaggerated relative to the actual threat. So what do we do? You're probably here because you know something about exposure therapy and the treatment of fear, and it works. And generally speaking, it works well. Like scientifically, fear extinction, like that works. That's a thing, and we've known that for like 100 years now. That said, doing it, implementing it, getting a person to do it well, and as a therapist, knowing how to implement it well, that's where the arch of the therapy, that's where we have the challenges. And we know that only about half of folks, maybe a little bit more, half achieve what we would call a return to normative functioning. So they're out of the clinical range of their symptoms, whether it's OCD or social anxiety or specific phobia or whatever it is, panic attacks. And we also know that many people, even after they do exposure therapy, that there's a return of their fear, that at some point after therapy ends, that for a number of folks, there's going to be a return of that anxiety. So let's talk a little bit about what we know about fear and fear learning, and particularly the role of context. And this is going to be really important as I talk about this for the next little while. Fear acquisition, so learning to be afraid, right? Which is kind of, from a cognitive behavioral perspective, we don't know how it works. We don't know why some people are more vulnerable, but we assume that, I'm just going to say anxiety disorders, right? And as encompassing fear-based anxiety disorders, OCD, PTSD, health anxiety, they are learned, right? They're learned through experiences that we have in our environment. And that's context independent. What do I mean by that? If I'm bitten by a dog, and maybe it's a German Shepherd, right? And maybe it's a brown German Shepherd, then all of a sudden I learn to be afraid of dogs in general, right? In my mind, I have a schema of what's a dog. German Shepherd is a dog. Dogs are dangerous, right? So it's context independent. Fear acquisition is context independent. That fear of dogs can occur in any context with any sort of dog. But if I want to get rid of my fear, if I want to extinguish my fear of dogs and learn that dogs are safe, that's context dependent. So if I do exposure therapy to playing with a poodle, right, or playing with a dachshund, or playing with a Great Dane, then I'm going to learn to not be afraid of those dogs. I need to do exposure to different types of dogs, lots of them, in different contexts. I need to do it inside and outside and in the park, and it's got to be a dog that I know and a dog that I don't know, to kind of whittle away at that learned fear. Learned safety is just a lot harder to come by than learned fear. And if you think about it from an evolutionary perspective, like that's good. We should become more afraid of things more easily because it protects us from harm. And it should be more difficult to learn that something that we perceive as dangerous is really safe. That probably has protected mankind, humankind, down through the ages. And this is going to come into play, with using inhibitory learning. So if we get all like Pavlovian, reducing fear requires lessening the fear stimulus, so the conditioned stimulus, the dog in this case, reducing its ability to predict the feared outcome, right? Which would be a dog bite, the unconditioned stimulus, right? A dog bite is unconditionally like that's harmful, right? That's painful and very unpleasant. So we need to reduce the ability for a dog, in my mind, to predict that I'm going to get bitten. How do we do that? We do that by using extinction techniques like exposure. So we repeatedly present, and this is an OCD example, we repeatedly present the conditioned stimulus, in this case, a toilet, touch the toilet, use the toilet, whatever, without the unconditioned stimulus, right, getting sick. So the person can see that, if I use a toilet over and over and over and over again, and I don't wash and I don't, avoid, then eventually, and I see that I don't get sick, as is generally the case, then eventually that association between toilets and getting sick is weakened. If I play with dogs over and over again and I see that I don't get bitten and that dogs are okay in different contexts, so here we're talking about different toilets, different bathrooms, talking about different dogs, eventually I'm going to weaken that fear, and dogs will again be perceived as being safe. Toilets will be perceived as being safe. Now, emotional processing theory is kind of this idea of how exposure therapy works that was brought about largely by folks like Jack Rackman, Edna Foa, Michael Kozak back in the 70s and 80s. And what they wrote about was this idea that we need to break the connection, that there's an association in memory between the conditioned stimulus, the trigger, and fear and anxiety, and which is a conditioned response, right? The person now comes to be afraid of the conditioned stimulus, and we break that, right? Literally, by doing exposure, we activate the person's fear, and then we present them with information that's incompatible with the fear structure. So touch the toilet over and over again, you don't get sick, that's incompatible with the view that toilets are dangerous, and I learn toilets are safe. Hang out with a dog, see that you don't get bitten, and I learn, and the idea here was that we know emotional processing is happening if there's habituation within the session and between the session. What's habituation? So it's just this idea that naturally over the course of time, distress goes down. If I play with a dog that I am, at first afraid of, over time, this pattern is going to happen. Right? If I give it enough time, maybe not 60 minutes, maybe shorter, maybe longer, but eventually my fear is going to habituate. Right? And that's within session habituation. There's also between session habituation. Right? So if I do this again, I'm going to start off a little bit lower and my distress might go down faster. And that's called between session habituation. The fact that, I continues to get easier and easier, less and less anxious each time. And generally speaking, this happens. Habituation is a fact, and generally speaking, it happens. But Michelle Krask and her colleagues found, they did a meta-analysis, and they found that habituation is actually not that reliable of a predictor of long-term outcome. In other words, folks can have habituation and yet they don't get better, or their fear returns at some point. And similarly, we can have successful outcomes even despite a lack of habituation. So my anxiety didn't go down, and yet the person's getting better. So habituation is nice because, sure, we would love to feel less anxious, but it's actually not necessary. And we're going to talk a little bit about, this is just something I want you to keep in mind. Sometimes when we emphasize habituation too much in therapy, it can actually lead to to backfiring. So what do I mean by that? We see some patients who use their exposure to control their anxiety. And I've worked with these folks, and if you've done work in this field, maybe you have too. Person comes in and says, oh, I was really anxious about X, and I did exposure to it, and my anxiety went down, and then I was good, right? Or I'm going to come in and I'm going to do this exposure, and I know that by the end of the session, my anxiety is going to come down, and all will be right in the world. And so the message that's being sent when you do exposure that way, when you reinforce that idea, is that anxiety somehow is like, we need to get rid of it. I can't tolerate anxiety, or it's not safe, and I need to wait for my anxiety to go down. Otherwise, treatment is a failure. And the problem with that is that, like we talked about, anxiety is not unsafe, and it is tolerable. It's unpleasant, but it's not dangerous. And so inevitably, at some point, a person with an anxiety disorder is going to become more anxious at some point. And so the inevitable future, return of anxiety might be misinterpreted as a sign of danger, a sign of relapse. Oh, I'm not getting better. My anxiety isn't going down. And that can get in the way. If the person develops, or sometimes they have, a fear of fear, which we call anxiety sensitivity. So Michelle Krask and her colleagues, about maybe 10, 15 years ago, developed this inhibitory learning. Actually, it's been on since even before then. Folks like James Boughton, even 10 years before that, were kind of talking about this. But Michelle Krask really nicely laid it out in a couple of articles in the journal Behavior Research and Therapy. And the idea is that during exposure, during extinction trials, that original connection between, again, we'll say the dog and getting bitten, or the connection between the toilet and getting sick, is not erased. But instead, what happens is the person develops a secondary relationship. So conditioned stimulus, no unconditioned response. So in addition to dog bite, we also have dog no bite. Right? So they're competing responses, right? The threat-based response and the safety-based response. And these two competing responses are in the person's mind. They're in the person's memory. And the hope is that let's do exposure in a way that inhibits the threat-based perception, the threat-based associations, so that the next time the person's around a dog, the safety-based association will kind of win the day, right? Will extinguish the threat-based association. And that's really what inhibitory learning is. We're learning in a way that inhibits the threat-based association. I mentioned the return of fear. And so this is important to talk about as well. There are three ways. Folks talk about three ways that we can have a return of fear after extinction, right? Exposure therapy, for example. One is just a spontaneous recovery. Like somehow, for some unknown reason, the person's afraid of dogs again, even after maybe years later, just after a delay, after an extinguished fear, they just, it's basically like, we can't explain it, so it's a spontaneous recovery. But then there are other things that we can explain. So we can have a context renewal. The conditioned stimulus is encountered in a new or a different context from where extinction took place, right? So if I'm afraid of dogs and I always do exposure therapy with my therapist's dog, right? Let's suppose he or she has a nice Cocker Spaniel and I do exposure to that. And now, I'm feeling good. But then, a couple of weeks later, I'm walking down the street and, neighbor has some dog starts growling at me, right? And I'm right back to where I was because it's not that therapist's dog. It's not the Cocker Spaniel, right? And so that's a context renewal. It's a new situation. Or maybe this dog starts growling at me, right? Remember, we talked about it's harder to learn safety, right? Safety learning is context dependent. So we can have a context renewal. And then we can also have reinstatement or rapid reacquisition. And this is where there's some sort of adverse event that can lead to the return of conditioned fear. You guessed it. What if the person gets bit by a dog? And so that extinction, right, that connection is repaired, right, after extinction. Right now I'm back to square one, basically, because the dog bit me. What we want to do with inhibitory learning-based exposure is maximize the likelihood that the safety-based associations are going to inhibit the retrieval of the fear-based associations. Real quick, not to beat a dead horse, but what are the differences between emotional processing and inhibitory learning, right? So the critical differences are, one is the goal of exposure. You're going to see this. Maybe it's not beating a dead horse, but we really haven't talked about this. We want the person to remain in the situation. I'm sorry, in emotional processing, we want the person to remain in the situation till the anxiety goes down, right? Till habituation occurs. That's kind of the old way of doing it. I'm not saying you should never do it that way, but I don't do it that way very much anymore. In inhibitory learning, the goal is to remain in the situation until the patient no longer expects catastrophe. What's the difference here? It's a more of a cognitive focus, right? We're changing expectations. Keep that in the back of your mind because we're going to talk about that too. Relation to anxiety. So in the emotional processing habituation model, anxiety is supposed to go down over time, right? You sit with the anxiety till it goes down over time. In the inhibitory learning perspective, we are teaching the person anxiety tolerance. So it doesn't matter if anxiety goes down. Yeah, it'd be nice if it goes down. Sure, you'd like that better. But even if it doesn't, we're still okay. Anxiety tolerance. So what we're going to be doing, again, desirable difficulties, we're going to use techniques that make short-term learning more challenging. And that's actually going to slow the rate that fear declines. So we're not going to worry too much about habituation. But in the long run, these same strategies are going to enhance that inhibitory learning. The long-term retention and generalization of the new safety learning, right? So that the person can go into real world settings and see any dog and say, oh yeah, that's a dog. I've done exposure to so many different dogs in so many different situations that I'm not as afraid of dogs as I was. And also a big push of this is on strengthening fear tolerance. And I can get through that anxiety and that distress. Michelle Krask, of course, does research on panic. She developed this around panic to treat panic attacks. But it really does extend to any sort of fear-based disorder. Okay, so using exposure to foster fear tolerance. If exposure can instill greater fear tolerance, right? So that's one less thing the person's afraid of. And that's going to help to stave off the return of fear, right? Because feeling anxious, that's a context in itself as well. So we want to look at anxiety as an opportunity to practice. Let's lean in, as opposed to signs of failure. We want to encourage a bring it on attitude, right? I can do this. And we know that from Albert Bandura's work, a big part of exposure therapy is self-efficacy. I can do this. And like I mentioned before, we want to be on the lookout for folks who are misusing exposure to control anxiety in the way that I talked about before. So another way to think about this is that inhibitory learning techniques move exposure further away from fixing anxiety. And instead, and I think this maps on a lot to what we do in ACT, we're promoting an open-mindedness toward anxiety, fear tolerance. We're going to welcome that. We're going to make room for anxiety because it's a normal and a safe experience. Okay, now let's get to the strategies. What can you do, like at 4 o'clock or 4:30 with the next patient that walks through the door, or maybe tomorrow if it's the end of your day? We're going to talk about a couple of these different strategies we're going to talk about all 5 of these strategies. The first is framing exposure to disconfirmed threat-based expectations. So if we're going to maximize fear extinction, exposure needs to be designed to disconfirm those elevated threat-based expectations about the probability of outcomes. So how likely is it that they're going to laugh at me? How likely is it that I'm going to get stung by the bee or bit by the dog? We also, we want to disconfirm expectations about how awful the feared outcome would be. And if that dog bit me, it would be awful, 101% awful, right? If I got laughed at in the social situation, I would die of embarrassment, right? We want to help folks to see that that's not true. And importantly, we want to disconfirm expectations about the inability to manage anxiety and uncertainty and unwanted thoughts and unpleasant body sensations. So the person is kind of like, I got this. No matter what, the probability is low. If it happened, I would be okay. It might not be fun, but I'd get through it. And I can manage all the internal stuff that shows up when I'm feeling afraid. Expectancy violation is the term that Michelle Krask uses for implementing exposure this way. The mismatch between expectation and outcome, right? We need to be able to drive a truck through that mismatch. I expected that snake would bite me. Oh, and the snake doesn't even care about me. He's slithering away from me. I expected that I would get sick from using a public bathroom, but I've used 30 of them this month, and I'm doing just fine, even though I haven't run home and taken showers, right? And what that does is that helps the person to develop alternate, in these inhibitory expectations. Oh, snakes are, if I'm walking in the woods and there's a snake, I'm okay, right? If I have to use a public bathroom because I can't hold it in until I get home, I'm okay. So we want to design exposures to accommodate what the client needs to learn. And that's different from saying, well, what would make you really anxious? Let's make a list of all the stuff that makes you anxious, and let's do them one after another. Nope. Here is, you're doing the work on the front end thinking, what's the cognition that we need to change? What's the overestimate of threat that we need to challenge? And we're going to tie the exposures directly to those expectations for aversive outcomes. So if the person says, I'm afraid to exercise because it'll throw me into a panic attack and I'll have a heart attack. Boom, you've got some predictions right there. And you want to design exposure, and it might look the same as habituation-based exposure, but under the hood, you're thinking, oh, we're doing this not to have anxiety come down. We're doing this to prove a point that you can exercise and you can have your heart rate above 140 for a half hour, and it's actually good for you, and you won't have a panic attack, or you might have a panic attack, but you certainly won't die. And we want to maximize the discrepancy between the predicted outcome and the actual outcome. And we can do a functional assessment, very important in CBT. We got to know, what are those fear cues? And they can be situations, they can be body sensations, they can be, thoughts, other sorts of private experiences. We got to know the threat-based expectations, those feared consequences. What's going to happen if you get on that treadmill for, 10 minutes? Oh, I would survive. I would drop dead. What's going to happen if you go to that party you've been avoiding? They'll all laugh at me, right? Safety cues and the behaviors that predict safety. So person with anxiety often is using compulsive rituals or other safety behaviors that get in the way, as we'll talk about later, of proving this point, because we got to stop those safety behaviors. So an example is person with OCD. This is Allie. She predicts that writing the number 13 on a picture of her mother will cause her mother to have a car accident. She avoids the number 13, any combinations, right? So again, rhetorical question, what's the conditioned stimulus? Obviously, right, it's the number 13. She's learned to be afraid of that somehow. What's the feared outcome? That mom's going to have a car accident. And what's the safety behavior? It's the avoidance, right? So what does Allie need to do for exposure? Well, we need to confront that number 13. In particular, write it on a picture of her mom to see that's very unlikely that her mom would have a car accident if you did that. She doesn't have to be worried about that. Again, from an habituation perspective, you could say, oh yeah, we got to confront the number 13 and sit there till your anxiety comes down, right? You see the difference here. We're thinking about it from a more cognitive perspective. So we're using exposure to test out expectations. And then afterwards, as you'll see in a minute, we're going to ask the person, hey, did it happen? Did your mom die in a car accident? Hey, how was that party? Well, they laughed at me. I felt uncomfortable. Okay, was it as bad as you thought? Right? Was the anxiety as unmanageable as you thought? And if you set it up correctly, they're going to say, I got through it. And you're going to discuss the discrepancy between what the person predicted and what actually occurred. We call this expectancy tracking, setting up the exposure to violate those expectations rather than reducing SUDs, right? Subjective units of discomfort. We want to maximize that mismatch between expected outcome and actual outcome. And before the exposure, you want to identify the nature and the strength of that expectancy. Oh yeah, 70% chance my mom dies if I write the number 13 on a picture of her. Right? I wouldn't be able to, if I became anxious in driving, I wouldn't be able to tolerate it. I would have an accident, right? I could only go on a treadmill for 10 minutes before my heart explodes, right? So it could be a length of time. It could be an anticipated, level of distress, or it could be some sort of, negative, tangible outcome. You want to specify what that is. Now, you can track subjective units of discomfort during exposure. There's some advantages and disadvantages to that. An advantage might be it helps the client to verbalize their feelings, and we'll talk about this later on. Sometimes that can be helpful. It's also beneficial if the client says, well, I can do 30% anxiety, but if I get up to 50% anxiety or 70% anxiety, I just can't handle it. And then you can track their SUDS, and when they're at 75, 80, oh, wow, so how you doing? Are you handling it? Also, tracking SUDS can foster the learning that anxiety is temporary. The person gets to see, oh yeah, I was a 75 like when we started, like a half hour ago, but now I'm a 30. Wow, that's pretty cool. The disadvantage, as we said, is that it could suggest that the goal is to reduce anxiety. So you don't want to say, we're going to sit here till your anxiety goes down. And it could also reinforce the need to control anxiety. So you know your patients and clients, and you can decide, whether this is appropriate. Some things to consider would be if the client has beliefs about anxiety. I can't stand anxiety, right? What's called anxiety sensitivity. I'm afraid of anxiety. Well, you might want to call attention to how anxious they're becoming, right? Will SUDS ratings impact what's to be learned during exposure? Well, focusing on the anxiety, will that get in the way of what I want the person really to learn? You may or may not end up tracking SUDS. Another important aspect to consider is, when does exposure end, right? Because I've had people, when I give workshops, sometimes like, so do you wait for the SUDS to come down 50% and then you stop? Do you wait an hour and then you stop? What if the SUDS hasn't come down, right? Technically, exposure ends when those expectations have been violated, right? And that's usually by some sort of condition or duration. What do I mean by that? The person expected the dog to bite them, and they've hung around with a dog and they haven't been bitten, right? That's the condition, right? And we want to do that many, many times over and over again. And the duration, well, I think, you can say to someone, so how long do you think before this dog bites you? Oh, 5 minutes. 5 minutes, and I will be looking like a wiffle ball from the dog's teeth. And then 5 minutes goes by and the dog is very nice, right? You want to find a nice dog, which doesn't mean dogs can't bite. I think we'll get to that in a little bit. Yeah, so, it's been 10 minutes, been 20 minutes. What's going on? The dog hasn't bitten you. What's up with that? Oh, well, maybe this dog is safe. Yeah, let's find another dog, right? Context dependent. But duration also, you've been exercising for an hour. You've been on this treadmill walking for an hour. Your heart rate is up. How come you haven't, passed out? How come you haven't had a heart attack? And the person learns, well, maybe that's not so dangerous, right? So conditions and duration. And again, habituation may or may not have occurred. If it occurs, great. The person learns, anxiety goes down, fantastic. If it doesn't occur, the person learns something really arguably more valuable. My anxiety doesn't have to go down, and I can get through it. Desirable difficulties, right? That's what I want. After exposure, we're going to consolidate that learning. We're going to ask patients to summarize what they learned. I give them a worksheet, which I'll show you in a second. And we're going to explicitly contrast. Here's what you thought would happen, and here's what actually happened. Or I would ask them, hey, what did you think was going to happen, and what actually happened? Oh my goodness, how do you explain that, right? And we're going to help the patient to point out that their direct experience shows that, yeah, I guess I made a mistake. Maybe this isn't as dangerous or as awful or as likely or as unsafe or as intolerable as I thought. And that's what we want. There is nothing like direct experience to help someone learn that. You can't talk someone out of that. It sounds like you're going to have a talk at some point on inference-based CBT, ICBT, what Lisa was saying. I see Lisa smiling. And they're going to tell you that you can reason someone out of OCD. I'm not convinced. You can tell them I said that. I'm up for a good debate about that. I think there's nothing like real experience. Experience is just the best teacher. Think about how many times have you tried to talk someone out of anxiety and OCD? It just doesn't work. This is the form that we use in our clinic. You are welcome to take a screenshot of that, use it, disseminate it, whatever. The more people that are doing this, I think the better. So no, you don't have to pay anyone for using this. It's also in books that I've written. Now, we do have to talk about this. There are different presentations of fear. So like a dog, you can tell pretty quickly, right? Either I get bit by a dog or I don't, right? And even like in the bathroom, like I get sick or I don't after a couple of days. Or a social situation. I'm going to die of embarrassment if I go to the work party at, the holidays. Either you die or you don't die, right? Either everyone laughs at you or they don't. Or panic attacks, right? People with panic often, I'm going to have a heart attack, a stroke, I'm going to lose my mind, whatever. You can tell if that's going to happen. And that's the most straightforward. But sometimes presentations are less straightforward. And I do a lot of work with OCD. In the OCD world, we see a lot of these less straightforward. So what if the feared consequence won't occur for a long time? What if I get cancer in 10 years because I went in a building that has asbestos, right? Or unknowable feared consequences. What if I go to hell when I die because I've had too many sexual thoughts? Or what if I'm really deep down a child molester? Well, you can't really know that. A person with OCD is trying to figure that out with all get out. That's how they spend like a lot of their time. But you never really get the answer to that. No one does. Or no apparent feared consequence. So that feeling of like, I'm just going to feel germy or disgusted. And I'm not afraid of getting sick, or the not just right experiences that some folks with OCD have. So what do we do then? Let's talk about how we implement that. What we want to do there is we want to try to figure out a way to make the threat-based predictions more immediate. So the person who's afraid of, what if I'm a pedophile, right? Might say, what's the fear, right? I can't let myself think about having sex with my son or with a child or something. I can't even let myself think about it. And I could never go to work if I'm having that thought in my mind. I could never be around a child if I'm thinking about having sex with them. Well, that's an immediate prediction, right? I can't let myself do it. So what are we going to do in exposure therapy? It sounds like we're going to do some imaginal exposure to thinking about having sex with your son, maybe writing a scenario, something like that. And maybe even you're going to put that in your pocket and take it to work with you, or you're going to think about it when you're with your kid or something like that, to help the person to see, look, you're better at these thoughts than you thought you were. You can do it. I can't tolerate knowing if God loves me. Well, the truth is that no one knows that for sure, because if you even believe in God, it's supernatural, right? So we're all tolerating uncertainty about God and if God exists. I know people have really strong beliefs, some people that God does exist, some people that God doesn't exist, but the truth is that that's faith. We don't know. So we all tolerate not knowing. So if the person says, I can't tolerate not knowing if God loves me, right? We can kind of do the same thing and help the person to, lean into, I don't know if God loves me or not. This is faith. And faith means kind of, believing in something, even though I don't have a 110 ironclad guarantee, right? And so helping the person to really lean into that kind of uncertainty like we do with someone with OCD. I'll be paralyzed from the anxiety. Right? Again, how long will it take till you're paralyzed? I can't bear to feel disgusted. Let's go into a situation where you feel disgusted and see that it's unpleasant to feel disgust, but you can bear it. You can stay in that situation longer than you thought. How long before you would have to run away from the picture of a person throwing up that looks disgusting to you? 10 minutes, and then I couldn't do it anymore. Well, let's see if we can make it for 11 minutes. And the person's learning something. I'm better at that than I thought. not just right. I will lose my mind if things aren't arranged just right. Well, we can arrange things not just right and really test that out. So we're helping patients exceed their predictions about not being able to continue exposure, or in some cases, not use their safety behaviors. I would have to wash my hands. I would have to, pray or something like that. You can function the rest of the day without reassurance of whether you're going to heaven or hell. Most of us do, right? Or if there's even a heaven or hell. How long do you think you can last with those feelings of disgust? That's the question you want to ask. And when they say 8 minutes, you can say, let's see if we can break that record. Maybe you can do 9. So what do we want to do? We want to make sure to clearly operationalize the feared outcome, decide on those indicators. Is it 8 minutes? Is it when you faint on the treadmill? Is it when you have a heart attack? We want to be specific, right? So think about how you would operationalize. I'm going to go crazy. I won't be able to function. What does that mean? Right? Will your boss come in and say, oh, you're not functioning today at work? Right? People often say to me, I can't function at work. So my first question to them is, oh, so you must be getting like bad reviews from your supervisor. Maybe your job is in danger. Oh, no, nothing like that. Oh, so what do you mean that you can't function? Right? And again, we can get more specifics about that. What does it mean when a person says, I'm going to have a bad day? Doing this exposure is going to ruin my entire day, right? Well, let's be specific about that. What do you mean? And then we can test that out. Now, if you do cognitive therapy or CBT, then maybe you're thinking, well, what's the difference between this and behavioral experiments like Beck or Ellis or all that wonderful stuff? And maybe it's not all that different, and that's okay. The lingo is I think is a little different, maybe. So maybe you're already doing expectancy tracking. I am one who believes that there's not much new under the sun, and that a lot of these different approaches to therapy have a lot in common. And I believe that this sort of inhibitory learning exposure has a ton in common with cognitive therapy and behavioral experiments, and also with ACT. Okay. Variability. We're going to go through this a little faster because I want to make sure we have some time for questions. But that's kind of the most important thing, is this expectancy tracking stuff. But remember, we talked about variability, right? That's a desirable difficulty too. We want more opportunities for surprise. Oh, that's a bigger dog. I didn't think I could manage around a bigger dog, but look, I gave him a treat and he didn't bite my hand off, right? Fluctuating fear, right? My anxiety goes up and then it comes down and then it goes up. That gives the person more opportunities to remember, I can do this. I can do exposure. Right. And it also, when we vary up the exposures, different types of dogs, different toilets, different situations, different whatever, different social situations, that prepares us for real world settings. Because as soon as you walk out of the therapist's office, you can't control what happens to you. So we really want this bring it on attitude. So we can extend those inhibitory associations to new contexts, right, by decontextualizing. So different stimuli and locations, different types of trash cans, different, social anxiety, different people, doing exposures alone versus with the therapist versus, with a family member or someone else. The time of the session. Some people are afraid of driving, in the day, other people at night, so we need to make sure that that's extinguished also. Your internal state. How many people have had folks that come in and say, I was really anxious this week, so I didn't do my exposures, right? And I'm thinking, no, that's the perfect time to do them and see that you can do them even when you are feeling anxious. Medication use is also a context, right? Especially if someone's on a benzodiazepine. I did this exposure. It worked because I was taking that Ativan, right? But no, that's a context. We want folks to learn that they don't need to have that benzo on board in order for me to be successful. And I think SSRIs, which are commonly prescribed, somewhat of a context, but less of a context. I've talked about this. The therapy room is a context, right? When you're with a therapist. So can telehealth be something that is a solution, doing some sessions in person, some remote. Spacing out the trials over time is another way to vary the practice interval. Right? Don't do exposures every day. Take a break. It turns out that when you kind of forget an association and you relearn it, research shows that you actually retain it better, right? So expand the therapy sessions, particularly as you kind of progress through therapy, right? So maybe first twice a week, then once a week, then once every 2 weeks. And again, this is in contrast to that gradual exposure approach where you're just kind of moving up a hierarchy, right? When you use a hierarchy, you set up this expectation that, oh, we're going to start with the easier situations because you're not ready for the difficult ones. And so that can send the message that, anxiety is dangerous, right, at high levels, and the person starts to anticipate. So we call it an exposure to-do list now. And again, I don't say do this with everybody. But one option is you can select exposures at random, literally pulling paper from a container. That's more like what happens in the real world. You can also modify it to meet the patient where they are, right? So maybe we're going to follow a hierarchy because it's easier. And if the person's going to bolt, then we certainly want to go gradually, right? Better to do some exposure on a hierarchy than not to do any exposure at all, of course. And then selecting exposures based on life interference. What's getting in the way the most? Maybe we should start our exposures with that. And again, there are pros and cons to all these approaches. And, maybe at some point we can talk more specifically about that. Still, some patients may not be willing. So gradual exposure is better than no exposure. And, I'm going to skip that in the interest of time. So combining multiple fear cues is another way that we can optimize inhibitory learning, because inhibitory learning is going to be greater when the anticipated negative outcome fails to occur despite multiple fear cues present. Robert Rescorla called this deepened extinction or additive exposure, right? What do I mean? 1 + 1 = 3. Well, so remember the woman, who was afraid of the number 13. So if we just do exposure to the number 13 and there's no accident, great. Fear extinction, nothing wrong with that at all. And if we just do exposure to thinking about an accident and there's no accident, great. Fear extinction, no problem with that at all. But if we do exposure to the number, writing it on picture of mom, and we think about mom having an accident, we actually, and research backs this up, research on animal learning, human and animal learning, you get even better extinction than just using one of those, deepened extinction. So combine fear cues. This is that Far Side comic that you've probably seen before if you're in our field, right? Exposure to situations and stimuli, external situations. You can, at the same time, you can do exposure to obsessive thoughts and mental stimuli, traumatic memories, and exposure to physiological stuff, interoceptive exposure, which I think often gets overlooked by therapists who are not working with panic folks. Really, really helpful. I'm not saying you pour it on at the first session and they're like this guy in the Far Side, but you want to make sure to incorporate that at some point. It's going to deepen that. It's going to optimize that inhibitory learning. Again, not all at once. Go gradually. That's fine. Affect labeling. I mentioned that it can be helpful to talk about your anxiety. Linguistic processing means that we're verbally expressing the emotions that we're experiencing as we're experiencing them. And there's research, Michelle Krask has done some of this, to show that it facilitates these new safety-based associations. Does it augment the associative process? Maybe. Is it a form of exposure in itself, kind of leaning in rather than white knuckling it? Maybe. So what you want to do is when patients are doing exposure, have them talk to you. Use those emotion words. You see some examples there. I'm afraid the spider's going to jump on me and bite me. Rather than keeping that inside, let them verbalize that. They hear themselves making these predictions that then end up not becoming true. Now, affect labeling versus cognitive therapy. In cognitive therapy, it's the therapist, kind of asking these Socratic questions, right? And then trying to disconfirm those with logic. And I love cognitive therapy. It's like the greatest thing ever invented, maybe next to exposure. Exposure is actually the best cognitive therapy, right? Because it's in vivo, right? Cognitive therapy. So what are you telling yourself is leading to anxiety? I'm afraid the police are going to show up. Okay, let's look at the probability, right? Some things you might do in cognitive therapy. In affect labeling, you're reinforcing their verbalizations. I'm feeling really anxious. Okay, tell me more about that. Well, I'm afraid the police are going to show up. Great job. Let yourself notice those thoughts and feelings. What does that sound like? It sounds like act, right? And then lastly, attentional focus. So attention grabbing, conspicuous aspects of fear stimuli enhance inhibitory learning, right? You are going to learn that sharks are not dangerous when you're confronted with this, and then you never get bit by a shark. There's more of a gap between what you predict and what actually happens than if you see like a friendly shark in a cartoon, right? So we want patients to attend to the frightening elements of their exposure stimuli. We're not white knuckling it, we're leaning in. And that allows the newly learned non-threatening information to be noticed and processed better than it otherwise would. And that just helps optimize these new safety learning. So focused exposure means you're going to engage, you're going to pay attention to, right? Again, the external features, sights, smells, arousal-related private sensations, heart racing, dizziness, sexual arousal if it's someone who has OCD, a fear of molesting a kid. Mental experiences, those fear predictions, those intrusive thoughts, that uncertainty, focus on that. That's really important to bring up during exposure, as opposed to distracted exposure where you're diverting attention away. Right? Oh, I'm going to look at my phone, or I'm on a beach somewhere. I'm not really on a public toilet or something like that. That prevents, right, the person from really encoding what they need to encode in order to have that maximal difference between what they predict and what actually happens. Right? So we want to keep the client focused. Now, we can have unintentional distraction. I'm thinking of someone I worked with, they had OCD. They're terrified of floors. And we decide, finally for exposure, we're going to sit on the floor and do an exposure. This person's, really anxious. And we're sitting on the floor. And after 20 minutes, this was like after the Super Bowl a couple weeks ago. After 20 minutes, like we're talking about the Super Bowl, that the conversation just kind of went there. So yes, that's distraction, but it wasn't deliberate. Like, okay, let's forget about that you're sitting on the floor. Let's talk about the Super Bowl. Right? It was unintentional. The conversation went there. And what did I do? I was able to say, oh my goodness, we're sitting on the floor and we're talking about sports. Did you ever think you could do that? Like, no, I thought I'd be terrified and I wouldn't be able to concentrate on anything, but they could, right? And so again, that's you're disconfirming those expectations. And that just, increases, maximizes, optimizes that extinction learning. Now, don't let attentional focus become a safety cue. Oh, if I attend to this, my anxiety will go down, because that's like using it like a ritual, a safety behavior. So allow the client to learn that it's okay to attend to other things as long as they keep in mind that they're in the presence of the feared stimulus. They're tolerating it. They're doing their thing, and they're feeling anxiety, and they're in their feared stimulus. So the next thing is, yeah, you can go to work and do this too. Not just talking about the Super Bowl on my floor, right? So acting with anxiety is what we want. I'm going to skip this part because we are out of time, and I know that I want to take questions. But the last thing I'll say is that, of course, I've talked about the exposure side, but we also want to make sure that we're not doing rituals and other sorts of, safety behaviors, because those get in the way. They take away attentional resources, and they also cause misattributions of safety. I'm only okay because I took a shower after that exposure session. I'm only okay because I was keeping track of my heart rate when I was, on the treadmill. I'm only okay because I had a drink before I went to the party. Otherwise, I wouldn't be able to manage. So, we want to help folks to use, if they're going to use rituals, do it judiciously. I'd come back and give a whole nother talk about that. But what we really want to do is we want to make sure that they're giving up gradually. They're giving up these rituals. When I say judicious use, I mean, at the beginning, sometimes Like, I'm bolting from therapy unless you let me, wash my hands a little bit. Okay, that's fine. But eventually we're gonna not do that. So I'm gonna stop there, and we have a few minutes for questions. I don't know if folks want to write them in the chat or if people want to raise their hand.
I have a question. So
Fire.
I'm working with a client who has HIV contamination obsessions and infecting others with HIV, which he does not have. And the problem is that the feared outcome, the feared consequence is unspecified, like the time frame for that. So if I understand correctly, what I should be doing is have him do an imaginal exposure where he imagines his friends after he cooks with them. That's how he thinks he's going to if, infect them. That he imagines them calling and saying, I got the results of my test, I have HIV, or I'm not feeling well, something along those lines.
Yeah, I think that would be, that would be great. I think that lends itself well to an imaginal exposure. And are there rituals that he would do, like checking, things like that?
Mm-hmm.
Yeah. So no checking, like how are you feeling, or have you gotten sick lately, or stuff like that.
Okay. Yeah.
Yeah. And again, that's not all that different than what you might do before. We talked about this, but what you're going for is helping him to focus on, I can manage that uncertainty. I don't have to know if they have HIV. I can still go to work and hang out with my friends and do whatever, even though I don't know for sure.
Thank you.
And I don't have to do rituals, right? I can go longer than I thought without checking in. I do see some questions cropping up on Zoom. So how different is this under the hood work in terms of outcomes compared to a traditional habituation approach? That's a great question. And I'll just say flat out, I'm not convinced that it's any different. And I think that when we do, like, randomized controlled trials are awesome in clinical psych because they tell us a lot about like what therapies can work. But when you have like 100 people who get inhibitory learning based exposure versus 100 people who get regular old habituation based exposure, you're not going to find any significant differences. Why? Because some people need one, some people need the other. They're both going to be in both groups. It really is, I think it's, and my supervisors from graduate school would kill me, but there is a lot of clinical art and judgment that goes into this. Some of these things have been studied. So Michelle Krask, if you go to psych, what is it? Google Scholar, right? Michelle Krask, and actually our lab has done some studies too. There are a handful of labs now that have looked at this. Some of the studies do show a difference. We've not been able to replicate that. And I'm convinced that that's because, if you've met one person with an anxiety disorder, you've met one person with an anxiety disorder. And so that treatment needs to be so tailored. So I want to say before we end that, and I want to make sure that everybody hears me, I'm not saying stop the habituation model and do inhibitory learning from now on. This is another tool that you can use, in your tool bag. I like it because it's consistent with the way that I think about anxiety and its treatment. Extinction is a cognitive process. Fear is a cognitive, thing. But that doesn't mean that habituation doesn't work. But if you're running into trouble with habituation, you might want to try, some of these techniques out. So that's a great question. I appreciate that. Would it be possible to get a copy of your slides? I'm happy to send the slides to you, Lisa, and you're welcome to distribute them. Newbie counselor here. I have clients with emetophobia and treat clients versus telehealth. Any advice for the virtual field? Yeah, I'm actually working with someone now virtually who has emetophobia. I think you can do the same thing. So you might gradually do exposure to like looking at pictures of vomit and sounds of vomit. There is, I think it's like emetophobia.net that has stimuli that you can like use. And I think they're even graded like in a hierarchy that you can use to help folks, like YouTube videos of comics vomiting, cartoons vomiting, and then real people vomiting. And oh, you use that. Awesome. So yeah, I think it's about the same. And again, you want to zero in on the prediction that your client has. Like, I would throw up if I listened to the sound of someone else throwing up, and then I would, that would be terrible. I couldn't stand it. I'm not a fan of making people throw up for exposure therapy. I've never done that. I don't think you have to. I think that person with emetophobia has a fear. They've overestimated the likelihood that they will throw up. And so what we want to teach them, and they've made connections between certain body sensations, certain feelings, and throwing up. Every time my stomach feels uncomfortable, that means I'm going to throw up. If I eat this food, that means I'm going to throw up. And what we want to do is to help them, we want to disconfirm that connection, that those stimuli are not predictors of like just automatically throwing up. Again, everyone's different, so hopefully that's helpful. There are recipes for making fake vomit, yes. All right, well, it's 4:31 on my clock, but hopefully this was helpful, and good luck with everything. Lisa, I'll send you my slides.
Yes, thank you so much. This was
Yeah,
really helpful. Yeah,
always.
thank you.
Take care, everybody. Thanks for joining.
Care.
Thank you.
Bye.